What is up, everyone? Welcome back to the channel. It's been a very long time since I've done a vlog like this. Went through the process of dedicated doing step 1 and 2, and I really just focused on getting through those experiences, and then I made a few videos reflecting on that. During the past few months, I've been on elective rotations, which I've been doing mostly orthopedic surgery, so I wanted to take you through a week to show what that has been like. This week in my rotation is sort of our oncology week. So I think 3 of the 5 days of the week are with onc, and then I have a few sports med days, but the focus of the week is oncology. I went in this morning. I thought it was just going to be a full clinic day because that was what was on my schedule. There are 2 orthopedic oncologists at our hospital that kind of cover like the whole hospital system, which is crazy just because the hospital system spans most of New Jersey. So I was scheduled to be with one of them in clinic today. The other one had sort of a half day of clinic, and then afternoon was in the OR. And because of that, they thought it would be best for me to go with the doc who had the OR in the afternoon, so that was a bit of a nice surprise. So I just did clinic with him, mostly shadowing, and then we walked over to the main hospital for operating room in the afternoon. Pretty simple cases. One was just a biopsy of a wrist mass, so nothing too crazy, but it was pretty cool because you go in there, you take small biopsies, and then you actually scrub out and walk them right over to the pathology lab, and they take frozen sections of them. The pathologist looks at them under the microscope with the surgeon right, in real time. You're able to get a pretty solid diagnosis right then and there, so if, this isn't anything to worry about, if you can just close them up. If it is something that is a little bit more concerning, you have to do more of a extensive resection of the lesion. So yeah, walked back to the OR. It was thankfully nothing, and we just closed the patient up. That was one of the cases we did. Then this one after that was interesting. As orthopedic oncologists, they deal with a few different things. One, you would assume bone tumors, but that can include primary bone tumors or also metastatic tumors from cancer elsewhere in the body. And that's actually the vast majority of bone lesions. It's not a cancer that originates in the bone, it's cancer that's coming from somewhere else in the body. So like breast cancer, prostate cancer, stuff like that. So the second case was a patient who had a history of breast cancer that was treated many years ago. But unfortunately, there was a lesion found in her hip, just kind of incidentally. I don't really think she was having hip pain or anything like that, and because of her history, it's likely metastatic breast cancer that has returned. And one thing that I've been learning this week is a lot of times with metastatic disease like that, part of the treatment isn't actually resection. Those kind of things, depending on the kind of cancer, can respond really well to chemo. So the role of the orthopedic surgeon is actually to do like a prophylactic fixation in order to prevent sort of a pathological fracture. So if you imagine you have this tumor growing in the bone, it's going to eat away at the normal structures and then weaken everything, and eventually you're going to get a fracture. So in order to prevent that while the patient is undergoing chemo or radiation or whatever, you do some sort of fixation. And for any sort of like femur fracture, femur fixation, it's usually an intramedullary nail. So that's what we did. We put a long nail all the way down her femur. That will help her femur be stable while she gets the treatment that she needs. That's kind of it for right now. It wasn't too long of a day. I got out of there at like 4 o'clock maybe, so not too bad. So just gonna relax and read up on my one big case for tomorrow. All right, so today's Tuesday. I just got home from the OR, and it was a pretty insane day. So on Tuesdays, the ORs don't actually start until 8:15. Normally it's 7:30, but I think anesthesia has some sort of like department meetings on Tuesdays, so it starts a little bit later. So because of that, I wanted to take advantage and go to the gym before the OR because I knew it was going to be an insanely long day. So we only had one case today. It was basically a radical resection of an osteosarcoma. So that's a pretty dangerous, potentially malignant bone tumor. This patient unfortunately already had treatment for this and had a proximal femur replacement, but unfortunately it recurred. It was, spreading into their pelvis, so we need to do something else about it. The cancer was originally around the proximal or upper part of the femur, which is why the patient had a proximal femur replacement as sort of the initial surgery. It recurred and then started to go into the pelvis or the acetabulum, which is where the femoral head sits and articulates and forms your hip joint. Because it had spread into that part of the patient's pelvis, it became a much more complicated surgery. And as a part of the planning for the surgery, they got a CT, got a 3D model of the patient's pelvis and femur, and then they were actually able to use that 3D model to build custom cutting jigs, so things that we put on the patient's bone to know exactly where to cut it, and then also a custom implant, so once we took out the bone, we replaced it with metal. That was really cool to see. I'd seen something sort of similar to that maybe a month ago with someone who needed a shoulder replacement, but this was a little bit different. And initially, sort of what I thought the surgery was going to be was taking out that acetabular component and replacing it, and then just doing another proximal femur resection and sort of redoing what the patient already had done. However, it was apparently sort of a last minute game time decision between the surgeons. They saw some things that they didn't really like on the MRI, and they decided to do a complete femur replacement. Those two things together, the acetabular replacement and a total femur replacement, is extremely rare. The surgeons told me that this is probably one of the craziest surgeries I might ever see in my life. Like throughout residency, throughout my career, this stuff just doesn't happen that often. So I did feel, pretty honored to be able to see something like that. So essentially, we made an incision all the way up, like above the patient's hip, below their knee, and just opened everything up, and then slowly just began to resect everything away with a radical resection, which is what this was, and that's usually how malignant tumors are removed. You want to make sure that you're taking a lot of healthy tissue around the tumor just to ensure that you're sort of encapsulating everything and making sure you're going to limit spread and not leave anything behind. Because of that, we ended up taking out most of the patient's quadricep muscles, some of their hamstring, and like I said, just the whole femur all out in one piece. Then after all that was out, we could, see the acetabulum better, made those cuts, put the sort of replacement metal acetabulum in, and then we had a giant metal piece that was going to be the patient's new femur. And because of that, we also had to do some stuff to the tibia to essentially do like a knee replacement on the tibia side. So the two parts fit together and they could use the knee. So yeah, the surgery itself was probably like 7 hours, and then there was a portion where plastic surgery came in to help us close. Were thoughts of maybe needing to do a free flap to help cover or close the incision. They didn't have to do that actually, just because we took out so much tissue. So 2 plastic surgeons, 2 PAs, one of the oncologists and their PA. So 6 people were closing the patient up at the same time. That was crazy to see, but it was just such a big incision and so many layers to close that they needed all those hands working. So yeah, really crazy experience. Like I said, the doctors were like, yeah, this really doesn't happen often. I was talking to one of the PAs who works with the oncologist who had been working there for 5 years, and he said that this sort of surgery has only happened twice in the past 5 years that he's been working with them. So if you think about residency, which is 5 years long, if I'm not going into oncology, yeah, there's a chance that I will see this 1, maybe 2 more times in the rest of my career. So really cool to be able to see that, and just really nice to see sort of the blend of technology and medicine. And without the help of the CT scan and the company who made the custom implant, we probably wouldn't have been able to do this surgery. So that's it for right now. I'm gonna eat and just go to bed probably because I am tired. Tomorrow is going to be a bit of a lighter day. We start every Wednesday morning with resident didactics, so that's from 7 a.m. to 10 a.m. And then I just have a clinic day in sports clinic, so should be pretty easy. All right, so today's Thursday. I just got back from the OR. Another pretty crazy day of surgery. So today we actually had two cases. The first one was pretty chill. It was just a biopsy. Then the second case of the day was honestly kind of similar to my case on Tuesday. It was just this giant sarcoma of the patient's leg. So on Tuesday, it was an osteosarcoma, so an actual bone tumor. This was just a sarcoma, so it was a soft tissue mass, but it was in the quad, so right, in the thigh, same area as the surgery on Tuesday. And same thing, was a radical resection, so we needed to make sure we were taking out the whole tumor in one piece with sort of a casing of normal muscle around it. Still a very intense, long case. Had to avoid a lot of the major blood vessels and nerves and all that in the leg, but just no actual bony cuts or anything. It was definitely a little bit more meticulous just because it was all soft tissue, and proximal part of the tumor was very close to the femoral artery and femoral nerve. So we just had to be extremely careful in that area, but we got everything out in one piece. Plastics again was called to help maybe close, but they didn't have to do any sort of flaps or anything. We're just able to close everything right up. So yeah, It has been really cool being able to see sort of these huge surgeries. It's nice to see the sort of variety that you get with being an orthopedic oncologist. You get a lot of innovation because of the, case that I did on Tuesday with being able to make custom implants for patients. So there is a lot that the field has to offer. I do think it is really cool that they work so closely with the pathologists. You do a biopsy, or in these bigger surgery cases, you take several margins all around where you remove the tumor, and then you walk them yourself over to the pathology lab and get to look at them under the microscope with the pathologist. So I do like that aspect. You get to, work with some other team members. In both of those big cases, we called plastics in, so you get to interact with plastic surgeons. So yeah, overall, a really cool field. I was talking with one of the surgeons, and they were saying that it is just sort of a ridiculously small field, though. He doesn't know the exact numbers, but he would say probably between 20 and 40 fellowship positions every single year. And even with that, the people who actually complete a fellowship, only about half of them end up doing orthopedic oncology in their career, just because there's not that many jobs out there. Like I said, the whole hospital system only has two, and they cover sort of all of North Jersey and Central Jersey. So definitely a small field, but it has a lot of appealing aspects. All right, so it is now the weekend. Last time I checked in, I think it was Thursday after that big sarcoma case. So Friday was a very late day. It was sports OR, just like in an outpatient surgery center. The first case was just a knee scope. I think the surgeon did like a partial meniscectomy because the patient had like a little bit of a meniscus tear, but I mean, it was so quick. It was like 20 minutes long. I didn't even scrub for it because there really anything for me to do. And because it was going to be so fast. So that was, quick and easy. And then the next one was a potential rotator cuff repair. It was kind of unclear based on the imaging. The surgeon wasn't convinced that there was an actual tear. And when they actually got in there, the rotator cuff was intact, but it was definitely very inflamed and angry. So that's kind of why the patient was having symptoms. But based on the patient's natural anatomy of their acromion, they sort of shave some of that away just to give the rotator cuff a little bit more space to live in. So hopefully this kind of inflammation and impingement won't happen anymore. So that was also a very quick case. With the rotator cuff repairs, they can be a little bit longer because you actually have to go grab the rotator cuff, pull it to the right area, put sutures and anchors in. But for this, it was just kind of cleaning up a lot of scar tissue and inflammation, and then just shaving away a little bit of the bone, so it really wasn't that bad. A pretty typical week of what I've been experiencing on these home ortho rotations. It's, we don't get a lot of interface with the residents. If we're scheduled to be in an OR and the resident is there, then, we'll be able to interact with them. But it's very different from like our core rotations where we would get to the hospital at 5 a.m. and pre-round and then, you know, go to sign out and present patients. It's really not like that. It's really more similar to living the life of an attending, where we are getting like 2 or 3 clinic days a week and then 2 or 3 OR days. So in that sense, it's a lot less stressful and less work. And I have, you know, more time in the afternoons to go to the gym and then just like generally study and try to learn more about ortho. So that has been really nice, but I do know that this isn't going to be the case on my away rotations. So I definitely need to kind of seek extra opportunities to learn different skills, like going and seeing consults and splinting and all that kind of stuff, because we just aren't connected that much to the residents, and that's a lot of what they do throughout the day. So yeah, that's gonna do it for today's video. If you enjoyed, please be sure to leave a like below and subscribe if you want to see videos like this in the future. Thanks, and I will see you in the next one.